I have to insert my finger into your rectum and examine the prostate gland.
My problem ain't back in that area, Doc.
Thank you, Doc. You ever serve time?
So how's this work? You just feel my pulse? Or
This isn't fair. It's routine, Jim.
I don't like nobody behind me like that.
Be very gentle, be in and out before you know it.
Do you have to breathe right up my neck? Sorry?
You using the whole fist, Doc?
what the hell was that? That's a prostate exam. Shut up! You had your finger in my ass! That's how a prostate exam is performed. Now, if you'll just let me... Get away from me!
Two brothers talking, telling it straight. One fought early, one was stage 4 late. Life threw a curve, but we're still in the game. Helping other families do the very same. We're laughing through the hard days, living every one. If one conversation saves a life, then we've already won. Know your number, don't wait another day. It's just a simple blood test, it could change your life today. Know your number, tell your brother too. We're living life to the fullest and we're doing it with you.
Welcome, everybody. Welcome, everybody. Okay, sit down, take the load off. Relax. Yes, we know you love the show. All right, we'll wait. These viewers of ours, they love it. Guys, this is a special episode of Two Brothers, One Prostate. We want to introduce our special guest today. This is Dr. Nabil Adra. So the world-renowned Dr. Nabil Adra. Dr. Nabil is a medical oncologist at IU, Indiana University Simon Cancer Center. He specializes not only in prostate cancer, but also testicular, bladder, kidney cancers, and is actively involved in clinical trials and survivorship research. So a lot kind of like what we do on this show. We do talk about prostate cancer a lot, hence the name of our show. But we also like to focus on men's health in general. A couple shows back, we did colonoscopies. We do all kinds of different things. So having Dr. Nabil here is absolutely a treat. Thank you, Dr. Nabil, for taking time out of your day. Obviously, being a world-renowned oncologist, you're probably a busy man. And taking a little time to visit with us is much appreciated. So,
thank you very much for having me. Yeah,
absolutely.
This is big. This is big. He is the smartest person we've had so far. What is this, episode 6 by far?
Well, obviously the smartest person we had. Last time we had our brother on. So, yeah, this is obviously the smartest guy we've had on so far. But a special shout out to Ashley and to Trisha, who hooked us up with Dr. Adra, who are very engaged, as well as Dr. Adra is in an event coming up here in Indianapolis, which we'll talk about a little bit later in the show. But first of all, a little bit about our mission, our goal in the podcast from all the millions of listeners that are watching out there. Our goal is really, again, is to educate, encourage, and inspire men and their families, through honest conversations. And we do get honest, real life experiences with a little bit of humor. Every episode, remind listeners to know your number, take charge of your health. And that's one of the reasons why we have Dr. Adra on here today, to kind of do a little bit about it. A little bit quick recap on our stories. So for me, back in 2023, 2.21 PCA, doing great, no issues at all. Come back again December of 2024 to give my yearly checkup. PSA jumps to 111. So obviously, I pooped in my pants. But what we found was that I had some kind of weird gene or something. So all of a sudden I have this aggressive cancer. I go in and get checked out. It ends up being stage 4 metastatic. And they put me on a clinical trial, which we can also discuss a little bit later because I know Dr. Adra is big into the clinical trials. And now today I'm sitting at a 0.19 PSA. So great, back to where I need to be. And the clinical trial is doing the work that it's supposed to be doing. And I have, right now, everything's pretty much sitting dormant, on all the stuff that's happening within my metastatic cancer piece. So I'm excited to get heading into that. Johnny, maybe you can hit us real quick with a quick story on your end.
Okay. So, first of all,
it's a doctor. I'm just kidding.
On a personal note, I was, all of my diagnosis was done at IU with Dr. Cooper, who, up at Fisher's, who was fantastic. So, once Kevin was diagnosed, my PSA was at a 3.6, but because of, Kevin, my just basically physician was like, why don't you see a urologist? I went and saw Dr. Cooper. He was like, let's get an MRI. And so he was very proactive and he was amazing to work with. And I had an MRI. They found 3 lesions, tumors, lesions. It doesn't matter what you want to call it, but either way, it still sucked. And then obviously the biopsy, which we talked about in nauseam on this show, and it's brutal, the biopsy, but it had to be done.
Click.
Yeah. And so I was basically came back with a Gleason score 8 on one lesion, and then the other 2 were 6s, and the one was right on the edge. So it was concerning. Obviously, they did a PET scan. It hadn't metastasized or spread. So I was a really good candidate, not a good candidate for radiation, but a really good candidate for a radical prostatectomy, which I did have done. I had it done by Dr. Large over at MD Anderson. I don't know if you know Dr. Large or not. I didn't have the procedure done at IU, but if it wasn't for IU, I wouldn't be where I am today. So they got me to, it was a village that got me healthy. So now I'm 9 months since my surgery. I am showing basically undetectable for any cancer. I'm still dealing with a few of the side effects that you know that does happen. It takes time, but I really am feeling stronger and better every day. And because of Kevin, I was able to be aggressive and really, find out kind of what was going on with me. And that's one of the reasons why we started the show was to, something good has to come out of this, and we can maybe help other people. So I'm really was excited to find out that we were going to have you on the show. And, IU basically is one of the organizations that why I can say I'm here today and feeling good and healthy and cancer free. So.
Well, yeah, officially I saved his life, Dr. Adra.
Oh, there you go. Yeah, that's right.
I'm dying. He's living. Slow process anyway. But so let's jump into a little bit of you, Dr. Adra. We did a little bit of research on you, as we always do when we have our guests on. So just little fun icebreakers. We hear you're a musician. You like to play the piano and the drums, I believe. Is that correct?
That's right. Yeah, used to actually, not so much anymore. But I still love to play the drums, piano when I was much younger. Drums, I used to play rock and so on. We had a small band growing up, so it was fun. It was good days.
I love that.
Are you a big concert goer? Do you do a lot of music? Do you go see a lot of shows, or you're probably pretty busy?
Used to go a lot of concerts. I got 2 young kids at home now. Got a 4-year-old and a 6-year-old. So life is a bit different after that happens. But used to love going to concerts. Absolutely.
You're just starting.
I understand.
You're just starting. Goodness gracious. Yeah, my kids are already grown. So are John's. So, we're just starting. You're just starting. So good luck on that. That's awesome. Kids, I love that.
Yeah.
Cool. So, all right. So, what inspired you? That's really, I guess we should get to the main interview here is this, what inspired you? What made you choose oncology? What inspired you to specialize in prostate cancer? Tell us a little about your path.
Inspired me to go into oncology. Medicine is a hard thing to do to start with. It's a lot of time commitment, lots of dedication. So I figured if I was going to do all that and put all that time and effort, I wanted to go into something where you can actually make a difference.
Yeah.
Not just another job. And, there's nothing more than oncology where you can make a difference. There's so much room for improvement, not just by seeing patients and delivering care, but by research, by clinical trials, by, developing new drugs, new treatments, and so on. So I love my job. I wake up every morning, love coming to work, feel energized. I was off last week, which is great. I love being on vacation, but, wake up in the morning, feel energized, come in and love seeing patients. And, more than seeing patients, I love, developing new treatments for patients, new clinical trials, new treatments, and treatments that can allow patients to, be cured of cancer. And if not cured, allow patients to live longer and better with cancer. Right. So,
yeah, really my goal at this point is to live as long as I possibly can. Obviously mine is still treatable, but I think we're maybe past the point unless there's something new coming out. So I'm on a clinical trial. Have you heard anything about the EVO Part 2?
Absolutely, yeah.
EVO Part 2, that's the one I'm on.
Targeted therapy trial, huh?
Yeah, so I'm taking saruparabib.
All right, good. Yeah, the
darolutamide. I'm taking 3 little pills in the morning and 4 of those big ass pills every day.
So also
absolutely.
in oncology, we like to make those names complicated on purpose. That way we look smart.
Exactly. That was my question. Who comes up with these things? Why can't we just call them? You know what I mean? If someone's sitting in the back room and they're like, "Hey, I got one sarubibitide." Okay.
Well, I mean, that's really bad. When I retire, that's the job I want, is to name those drugs.
Name the drugs.
Whoever's doing it now is not doing a great job. So,
I mean, I've got some other issues in my life, so I take some other medicines, and they've had some fun with them on commercials. I take Jardiance; it's really swell, big story to tell. I mean, they have a lot of fun commercials with the things, but where they come up with these names, it blows my mind. And then when that doctor asked me what I'm on, I'm like, what the hell? I don't know. Faralubidib, papadoobadoo, what's the difference, right? So, but it's absolutely just destroyed my hormones. I mean, it's killed my testosterone. So tell us a little bit about.
You must have like a genetic alteration in your prostate cancer and that's, part of the reason why you went on that clinical trial, is that right?
Yes, they did find that I had some type of mutant gene. So, but it seems to be working. I don't think I have the placebo, but one never knows, do one? But I'm pretty sure with the results that I'm seeing, I must be on the medication. But so it's a fun adventure, and that's why I got my Superman cape back here, buddy, because I like to think that not every hero wears capes, but.
There you go. It's part of, if you look at prostate cancer in the past 10 years, the drug development has just exploded. Prostate cancer was not one of those cancers where it was a lot of research, money, and dollars that was thrown into it. It used to be more in other types of cancers. But over the past decade or so, there's been so much development in prostate cancer, numerous new drugs that were FDA approved for patients with, localized and advanced disease as well, or metastatic disease. Just this past Friday, there was an FDA approval of a drug in, frontline prostate cancer. It seems like every couple of weeks we see an FDA approval for a new drug. I tell my patients that my goal is for you guys to put me out of business. If you guys put me out of business, that means we're doing a good job. We want patients to be cured. Coming from IU, a lot of what we did here is, a lot of the work that was done here by Larry Einhorn and others was with testicular cancer. He's the oncologist who developed a cure for testicular cancer. So people don't know this, but patients with testicular cancer with metastatic disease can be cured with chemotherapy. You give them a combination chemotherapy and they get cured, not just control the cancer, but cure. And I think that's what we should shoot for in oncology. We shouldn't just shoot for, let's shoot for longer life or like a couple of months longer life or whatever. We really should be ambitious. We should shoot, be very optimistic, and, we should aim for cure. And that's why we do this job, basically.
Please.
Yeah. Well. Kevin said. Kevin said that he didn't think he had the placebo. I can testify that I have had my prostate removed. Let me tell you, it's something you don't know you have it until you don't have it anymore. You don't even realize that you're going to miss it until it's gone. So, it is a. Do you feel like? Sometimes there's some misconception out there about how far they've come now with the radical prostatectomy, where they can really, I was fortunate enough to be able to have the nerve sparring surgery, and that has become such a game changer with the procedure, hasn't it? Where it's completely changed, how a man can get, in a way, I guess, back on his feet and get back to his life again.
Right. Yeah. I mean, the field has changed a lot, and I'm a medical oncologist. I'm not a urologist. So I don't do those surgeries myself. I treat with systemic therapies and treatments. But if you talk to urologists, the field has changed so much, and techniques with surgery have become so much better. And for the most part, if you can do a nerve-sparing radical prostatectomy, a lot of those long-term side effects are spared. Now, for some patients, it's not appropriate to do a nerve sparing if the cancer is extending beyond certain area. We have to take the nerves, but for patients who are appropriately selected, nerve sparing offers, great quality of life after prostatectomy. That's why also it's important for patients, and that's part of what I do is I tell patients, you need to be your yourself's best advocate. Like, you need to advocate for yourself. So get opinions, read about what you're dealing. Don't go through procedures. Don't go through treatments. Even if I'm recommending them, I don't want you to go through treatments without actually reading about them, being very knowledgeable, and feeling 100% comfortable with whatever choice you make.
Yeah. And I mean, that's the thing at the end of the day, like, knowledge is power. And you've got to really do your homework and go after exactly what is a best fit for you. And, for me, it was that. And, Kevin did his research too, like, what's going to be the best thing for me at this point. So, but I think one of the reasons why we started this in the first place is to kind of just be able to tell men our story so they don't maybe have to be in this situation. They can stay ahead of it and really know exactly where they are just by taking a simple blood test, right? I mean, it's really how far they've come now to be able to let you know kind of where you're at. And then you have kind of a baseline, and then you just keep an eye on it, right? I mean, isn't it that simple?
It is very simple. The PSA blood test is quite simple. Most people can get it easily. And it's not, the perfect screening tool, but it does fairly well. And it can track patients who are at risk of developing prostate cancer and can detect prostate cancer earlier. So for appropriate patients, I always tell, you should always talk with your doctors, talk with your family doctor or primary care doctor about prostate cancer screening. And us as a community with physicians, people like yourselves, we need to raise awareness that there's this misconception that prostate cancer is, it's nothing to worry about, right? It doesn't, that's
what I was told. And it's for old people.
It never kills anybody. That's completely wrong. There are people who are unfortunately diagnosed with prostate cancer and it's already traveled outside of the prostate to other parts in the body. There are lots of people. There are unfortunately people who have symptoms from prostate cancer, when it goes to the bone or other organs where they have a lot of pain or other symptoms. And unfortunately, there are people who die from prostate cancer every year. Yeah. Now, in some cases, it's a slowly growing cancer. In some cases, we don't even need to treat it. We can just watch it.
Right. That's what I thought.
It's a subset of patients. That's not everybody. And I think us as a community, we need to do better with educating people that not all prostate cancers are slowly growing cancers. Some of them can be very lethal and some of them can be fatal. So we need to take it very seriously.
I'm definitely in the aggressive form for sure. So
yeah, would you say how important is family history and hereditary? Is that a huge factor? Because our father had it, we had an uncle that had it. I mean, if you have it in your family, you should be really vigilant, I would think, right?
Huge. Family history, extremely important. And not just family history, the age that the person developed prostate cancer. So, if your father developed prostate cancer when they're 90, well, probably, it's some family history, but it's not huge because as we get older, we all develop prostate cancer. Yeah. It's just a natural thing. But if your father had prostate cancer at 50 or 60 or even low 70s, then you're more worried. And then if you have uncles and so on, so you all look at family history. The other big thing is race as well. African Americans tend to have a more aggressive biology with their prostate cancer as well. So, for African American patients, I always tell them to screen earlier and more aggressively as well, and be very cognizant with their screening too. So those are very important elements. And then you can watch your PSA annually. Ideally, if you develop prostate cancer, you want to catch it without any symptoms, but also monitor for symptoms. If somebody goes from no urinary symptoms to now you're having pain with urination, or you're peeing 4, 5, 6 times at night, or something's off with your urine tract, then you got to be careful. And we men tend to disregard symptoms. I know I do sometimes. A bit of back pain, bit of something. You just say, it's nothing. We'll figure it out. But don't disregard the stuff. Address them early, because addressing them early can be the difference of catching a cancer when it's very early, very curable, easily with nerve sparing or other minimally invasive techniques, versus several months later, if it grows enough, then you might need to take a bigger chunk of the tumor. You might have to take the nerves. You might have to do a bigger operation. Mm-hmm. Or even worse, it might spread outside of the prostate to other parts of the body. Usually it becomes not curable at that point. So
I feel like that's kind of where I'm at. Hoping that the clinical trial will keep me, going, keep the testosterone at bay is really the whole goal. I mean, it kills the libido. It kills a lot of other, I'm basically in male menopause. So, hot flashes, irritable, moody, but a lot more calmer, feeling more like a woman every day. And the hot flashes kill me. So I've got my big fans. I've got fans all over the darn place because it's just brutal. And that is the killer. And the libido is the worst part about the whole thing. So absolutely frustrating. So, but, you know, it's all part of the package. And that's what I tell the guys that listen and the females that listen to stuff is it's part of the package. You got to work through all this stuff, through counseling, through whatever, you know, what the best means are. But most importantly, your doctor, someone like, you know, Dr. Adra here who can help you out.
Well, you know, the other thing too is that not, you know, historically hormone therapy is a backbone of our treatments, but it doesn't have to be for every single patient. So as we're moving along and as we're developing newer drugs in the field, you know, some of the questions that we're starting to ask is, does every patient need hormone therapy? Or as our other drugs get so much better, like the targeted therapies with PARP inhibitors, or could we let go of hormone therapy? Can we use other approaches to target prostate cancer? So I can see a world 5 or 10 years from now where not every single patient with metastatic prostate cancer is on hormone therapy. There can be other treatments and then spare the hot flashes, night sweats, libido problems, and so on. So,
yeah, well, if you can keep me posted, you know, that would be great. If I can actually add some testosterone, I'd like to get back in the game, bro. You know what I mean?
We're treating patients with prostate cancer, you know, we want to treat patients, we want to, you know, get the best response, but we also want to see how patients are living, what their quality of life is.
Exactly.
And so if you kill all the prostate cancer cells and your PSA is very low, but the patient feels miserable and horrible, you're not achieving much, right? Yeah. So you have to sort of balance those out.
Yep.
Gotcha. I mean, my quality of life is still great, but, you know, I'm just playing with you. But, yeah, I mean, you know, it's pretty amazing change mentally, you know, because I was, you know, I can't say that I think about sex 24 hours a day, but at least 18. And now I'm doing more like, hey, chicken or pasta for dinner. Or should I do a combo and make like a creamy chicken and pasta? I mean, what has happened to me, Doc? What has happened to me? You know what I mean? Goodness gracious. But yeah, so now what excites you most about the next 5 years? Do you think you think we'll get to a cure before it's too late for me? You think is it plausible?
I think over the next 5 years, we're going to see multiple other new drugs come in and be available for prostate cancer patients. I think we're now in a world where, you know, in the past, when I used to meet a patient with stage 4 or metastatic prostate cancer, you tell them, well, we can control your cancer, but we can't really cure you.
Yeah, that's what I'm hearing. So
I think that can probably change in the next 5, 10, 20 years, just with the amount of research and drugs that are being developed. And it might not be that each one of those drugs alone would cure patients, but it could be a combination of these drugs, or it could be, you know, some surgery, some radiation to certain areas, plus systemic therapy. So, you know, when I see patients now with metastatic prostate cancer, you know, I tell them historically we used to say, yeah, it's not really curable at this point. We can treat it, but we can't really cure it. I don't know that that's true anymore. I mean, I think in oncology, I never like to say never. There's always hope.
Yep.
And so we're always hopeful. And, you know, I'd say for patients with dealing with prostate cancer, I tell my patients is the best treatment option, because they always tell me, well, doc, what would you do? What's your best treatment option? In my mind, the best treatment option is always a good clinical trial, because that's going to advance the field. That's going to give you the best shot of treating the cancer, and that's going to advance the field at the same time.
Plus, you're helping others, and you're a hero, and it's good stuff to support. Yeah, that's why I got my cape back here. Like I said, I got my Superman cape. I don't feel like a hero, but it feels good to know that I'm doing something that might help, you know, bring this thing to a next level and help other people, and
of course,
so forth and so on. So, you know, it's it is what it is. So yeah, keep me posted, because they're only giving me maybe 10, so I stay within that 5 to 10 range as opposed to going to 20. You know, just to be sure. You know, I mean, I may go past that, but, you know, here's the magic number. You know what I'm saying? So let's try.
And, you know, the other interesting too is that, you know, in the past we used to have drugs all from a similar mechanism. You know, hormone therapy, we lower testosterone, we target that. But now it's different, right? We have drugs that lower testosterone and drugs that target the androgen receptor, which is a protein on the surface of prostate cancer cells. We have drugs such as chemotherapy drugs that's more of like a shotgun approach. We have targeted therapy specific to the genetic makeup of each patient's prostate cancer. So that's individualized, personalized care for each patient. We have targeted radiation treatments. Those are infusions that go in the vein that find prostate cancer cells and introduce radiation into them. So there's multitude of different drugs with different mechanisms of action. And, cancer cells are very, very smart. So a lot of times when we want to achieve long-term remission or cures, the best way of doing it is to combine drugs that have different mechanisms. You attack the cancer with this way and that way as well. So it might outsmart this way, but now it's got 2 different or 3 different way.
You're sneaking up on the sons of bitches,
Yeah,
sneaking up on those little bastards and saying, "Hey, I'm going over here. Get ya!" I mean, that's the goal, obviously, right?
Yeah.
So how do you feel? So I told you I'm doing the Evo part 2. Should I continue forward with that? Is there a better clinical trial I should talk to my oncologist about? Should I just keep moving forward with this?
I would say if the trial that you're on is working well and your cancer remains responding well, then I would continue on it. Obviously, talk to your oncologist, see what their thoughts are. But I would say as long as it's working, as long as the imaging shows that the cancer is responding, the PSA is suppressed, then to me, I feel like you're in good shape. So
we're getting some mild shrinkage on the tumors, and we're getting stabilization. No new ones. Stuff like that. So I'm guessing that's good news, right?
Absolutely. Yeah. So
that's really good news.
With prostate cancer, it's a bit tricky too, because a lot of the lesions, a lot of the lesions in prostate cancer tend to be in the bone. And in bone lesions, we don't see those shrink much over time. They actually heal up. We call it sclerosis in oncology. So they heal up. So they don't shrink much on scans. So the fact that if it's in bones, it doesn't shrink too much. It's not as disappointing because it's something that we expect, actually.
Right.
Oh, okay.
Well, I'm hoping that I never have to do any of these drugs. So I'm hoping that them just removing it and I'm good. So we'll just have to see. So is there a certain, I mean, I know that you're not a surgeon, but like once it's removed, I have to do my blood tests every 3 months to just make sure that PSA is really non-existent. Mm-hmm. How long do you have to do that if you're like if someone like that was stage 2 like me that's now 9 months past and we're just I believe it's like every 3 months for a while, right? Until further notice, basically.
Yeah, so it depends on each patient. So in some patients who have a lower risk, there's something called Gleason score as well. I don't know, you probably know what your Gleason score is. But for a patient who has a higher Gleason score, meaning an aggressive prostate cancer, and a PSA that was elevated before surgery and went down, you will want to watch it very closely for a long period of time. So you might check it every 3 months for 2-3 years or something like that, and then start spacing it out. But somebody who has a lower Gleason score, let's say a Gleason 6 or 7, and the PSA was mildly elevated, it goes to undetectable, then you feel like that patient has a very high chance of being cured anyway. So you can space out those PSAs sooner.
Right.
So the frequency of PSA checks is not the same for every patient. It depends on certain risks from the patient, like what the Gleason score, what the PSA is, how old the patient is, and so on. But the main thing you don't want to do is you don't want to blow off, not saying about you, but general population, you don't want to blow off your surveillance or your follow-up PSAs. Because just as you don't want to blow off your screening PSAs, if you have surgery and you're scheduled to get PSAs every 3 months, and if you miss a few PSAs, and now all of a sudden you go to your doctor, you check a PSA, and now it goes from 0 to 10, well, that means that probably the cancer is back and it's spread somewhere else. Whereas if you check it regularly and you catch it when the PSA is still like, let's say 0.1 or 0.2, then that cancer probably is still somewhere localized down near where the prostate was, and you still have the shot at cure. You can still do radiation or some other surgical interventions or minimally invasive interventions like freezing and so on, and you can still get cured of that cancer. So if people take away anything from this, I'd say is just make sure to keep up with your follow-up schedule with your PSA checks. It's such a simple test. Don't miss any test. It might be the difference between being cured of a cancer or not.
Yeah, mine's a 0. Mine was like a 4.8 at its height right before my surgery. It's a 0.002, I think. So like we want to just stay there. So, but I would think even if it goes up a little bit, you're probably okay, but you really just want to keep it. You want it to be non-existent. I would think would be the best thing. And then it's gone, and you can, and breathe a sigh of relief. And I know Kevin has been very fortunate with what he's been doing, and but I know that it did get farther along than he wanted it to be. But if he wouldn't have caught it when he did, it could have been a lot worse. So we both consider ourselves we're very thankful and very blessed that we were able to be at least proactive enough, to make sure to catch it, because we really didn't have a lot of any symptoms. So
I had a few symptoms, and then when I got the symptoms, I immediately went and got checked. I had some blood in the ear and stuff like that, but that was a telltale sign that something was going on with me. And I was like a 10 on the Gleason, so I can't win the lottery, but I can sure win the Gleason scores. Great, give me the lotto, give me the Powerball tonight, and make up for it. God, what am I getting? You know what I mean? It's just, it's frustrating. So it's very frustrating. So, but, any other questions, Johnny? I mean, maybe just, maybe if you had like 1 minute on national TV to convince every man to get screened, what would you say, Doc? You have 1 minute.
In 1 minute, I would say a PSA blood test can be a difference between life and death, can be a difference between catching prostate cancer early and, dying of prostate cancer. That would be the first point. The second point is not every prostate cancer is a slowly growing cancer that is insignificant. Prostate cancer can be aggressive, can be lethal, can be fatal. Please don't underestimate it. We're not saying that everybody develops prostate cancer, actually, in the grand scheme of things here. But please get checked for it, get screened, and follow closely with your doctor if your PSA is elevated to get the appropriate procedures and move quickly. And ask for help. Talk with your friends, your community. One thing I'm very encouraged about is I feel like there's more and more talk about prostate cancer. Patients amongst each other. We're building a community, and it's become more of a topic that people are more comfortable talking about. Men used to be not very comfortable talking about this stuff, and I feel like it's becoming more and more common for men to talk about this, similar to this show, which is extremely important. So,
that's our mission. Outpacing prostate cancer. That organization, fabulous. We're trying to get involved with other organizations as well that we're have met with, and still waiting to see what comes of that. But I guess it's a good time to talk a little bit about the big event. So it's September 12th. Everybody out there, September 12th at the Scottish Rite, where ironically is where Johnny got married many years ago.
For 34 years ago, I was married at the Scottish Rite in just this past July. So it'll be really cool to be back there with my family in September on the 12th for the big event. We're really honored to be sponsors of the event and to be a big part of it. And we're really, it just is such a cool event. And this is something you started, correct, yourself last year. Where did you come up with the idea for a walk? I mean, was it just like, you're like, I just want to be able to get this word out. I thought this would be a good way to do it, or?
I'll tell you, yes, we started here at IU, and I'll tell you, my patients started it more than I did. It's because he kept on talking to me and saying, we want to build a community. So a lot of my patients were like, well, how can I help? They're so thankful. They're doing well. How can I help other patients? I've had many of my patients call each other, connect with each other. I've had some patients have lunch or dinner together, talk about their experiences. Because, when you get diagnosed with prostate cancer, it's scary stuff. I mean, you hear your doctor talk about treatments and maybe chemotherapy and targeted therapy, all this stuff. It's scary. But then you talk to somebody who's been through it and you feel so much better. So that was the impetus of it. Well, let's build a community. Let's get people together. And let's raise awareness first for prostate cancer and the importance of screening and so on. But also, let's raise awareness that we need to talk about these things. And a lot of it, too, is we need to raise awareness for importance of research, that it's what our current standard is. Although we've got great new drugs, the current standard is not acceptable. We need to do better. Mm-hmm. And I think our goal is to continue developing the standard so that most, if not all, patients with prostate cancer are cured of their cancer. That's when our job will be done. And so that's good. That's the purpose of this. Get people together, talk about prostate cancer, talk about research, clinical trials, educate, have fun. And then, so we do that for a couple of hours. And then we ended with a nice walk on the Indianapolis Canal, downtown Indy Canal here. And it's been a great experience. Our patients love it. Our community loves it. So we're very thankful for you guys as well for for helping spread the word about this.
Yeah, we're gonna have a booth set up. We're gonna have some giveaways. We're gonna get people involved again to learn about Two Brothers One Prostate as well. It starts at 10 a.m. There's a brunch, and I believe it's a free brunch. Who doesn't like a free brunch?
Yeah.
Come on and get some free brunch. A beautiful buffet, from what I hear. 10:30, there's going to be some expert insights. I get some talks and some questions, and people can certainly go there. 12 o'clock, a nice big old group photo, which will be fantastic. And then at 12:15, there'll be a walk that is optional, but we recommend everybody get out there and walk, because what's better to keep you healthy and laughing and having fun than having a walk and talking prostates. You know what I mean? There's nothing better to it. So I'm going to put this up here because I had John test before, because I'm not a master, but I'm going to put this QR code up here, and we'll keep it up there for a little bit. And, of course, people can rewind it when they're watching the show. But if you put your camera right up to that, you'll be able to get right to the site. Yep. You'll be able to register. Plus, you get a free T-shirt. You know what I mean?
You do get a free T-shirt. Hey, Kev, put it back up again and cover your face so me and the doctor can have a nice conversation. That's fantastic. So what else is going on, Doc?
guys. Okay. Yeah, so it's going to be awesome. Brunch, insights, walk, Scottish Rite Cathedral, 10 a.m. to 1 p.m., Indianapolis, Indiana. I will be there. My girlfriend will be there. Uncle Johnny's going to be there. We got our best friend, Petey, coming from New Jersey. Anybody that's in the Indianapolis area that's friends with John, which are tons, come on out. Visit us. People that watch the show, come on out. I'm sure you're going to be dying to meet us personally, because we're great individuals. We're going to have shirts. We're going to have some cozies to give away. We're going to have a little wheel. We're going to have some fun with it. Hopefully we'll get a chance to meet Dr. Adra personally. Very excited about that too. And then we'll take a nice walk. I'll take some breaks, obviously, but we'll take a nice walk as we're going.
Anything else that we missed about the big event on the 12th, or we cover it all?
No, I think that's pretty much it. It's a lot of fun, honestly. Everybody loves it. It's one of my favorite days of the year. We're all very excited about it. So
I watched last year's video of it, and everybody was having a great time. And you get to walk the canal downtown, which is, if you've never walked the canal downtown, it's great. I think you start from the Scottish Rite, and then you work your way to the canal, right?
That's right. Yeah.
Yeah. So it's going to be just a great time, and hopefully we get a beautiful day like today for it, and get to, I really want to get the word out to the younger folks like ourselves, that I continue to spread the word to like people that are our age. It's so important that they know, like, this is the time that you need to be really, 55, like, I'm 50, I'm 58, Kevin's 60. And this is when you need to be really keeping an eye on it. And just, know what's going on. And
it's a simple blood test. Talk with your doctor about it. Once you hit 50, ask your doctor if it's right for you. They'll ask you about family history. They'll look at your chart and sort of things, but bring that conversation up.
Well, just outstanding. Dr. Adra, I got to tell you, on behalf of every patient, caregiver, family member who watched this episode, thank you. Not just for joining us today, but for dedicating your career to helping people like me and my brother live longer, live better lives. We truly appreciate it. We thank you so much for your time.
Absolutely.
Yeah,
thank you
Thank you so much.
Two brothers, one prostate. Where health meets hilarity. Live every day to the fullest. Stay positive. Continue to laugh and love every day. Know your number. Know your number.
You can use your drums right now, Doc.